my thing. Yeah.
Okay, so now we're recording. So welcome to implementing the practice standards. Thanks for coming along, those that are here and made it this morning, and to those who will be watching this by recording at a later date. I'm Gina, lovely to see you here. And what we'll do is we'll kick off and get into the subject. Here's Shirley. Let Shirley in. Good morning, Shirley. Jane, oh yeah, look, I think people might have found it a bit hard, Lou, like you said, trying to make their way through. Hi everyone, sorry, we think maybe the emails didn't have the actual Zoom link in it, but they did have a pathway back to, get in, but it's a bit kind of convoluted. So everyone's probably going to come in a little bit late. Not to worry, I'll make sure Ali puts a link in every email that goes out. I think that would be the solution. So we'll kick off. I know that people are possibly going to be walking in as we go, but that's okay. We've had that before. And we'll also be recording this. It'll be available for 30 days to anyone who's attended. So lovely. So let's kick off. Share my screen. Share. There we go. All right, so what we're going to do is we're going to talk about the practice alerts, not practice standards. What a silly goose I am writing that in there. So this is me, Gina. Those of you who haven't met me yet, consultant, standards, auditor, SSO reviewer, under a number of standards, the NDIS standards, the Australian Retirement Villages standards, White Ribbon standards, and the ISO standards. So I'm a former allied health practitioner. I'm not registered anymore. A lead quality auditor, trainer assessor. I've got a lot of experience in government policy and a postgrad cert in ageing and disability from the University of South Australia. So what are these practice alerts that we're hearing about, or some people are not hearing about, we could even say? Practice alerts are a short research summary that provides important information on best practice, safe and quality service delivery to people with disability. They were developed in response to the scoping review of causes and contributors to deaths of people with disability. So in December 2021, our report was finished, and its findings were quite a good contributor to knowing what were the things that were shortening people's lives. Those who were receiving disability services, whether they be in their own home, but mostly, and of course you could imagine it would be a lot more magnified if they're in an accommodation service. So a lot of these practice alerts have come from that. So the NDIS Commission practice alerts identify and reduce the risk of avoidable deaths. So I think we need to remember that when I posted the new training on practice alerts that we put together soon after they started to enforce the practice alerts, I didn't really get much interest. People weren't really listening. They weren't hearing. The word practice alert wasn't really, words are really important. If they use the right words, they'll, governments and institutions will get the right reaction. But if you don't use the right words, you won't get the right reaction. If they'd used the words in the beginning, avoidable deaths, I think a lot of providers would have sat up and listened straight away. But practice alert is just another thing on the radar that has to go on the radar of a provider who's already juggling so many things. So the idea of this is to really bring home what those practice alerts were about, which is reducing the risk of avoidable deaths. So the quality and safety standards sought the review of causes to contributors of deaths of people with a disability in 2019. The Uni of New South Wales, most of the researchers came from University of New South Wales, completed the report, provided a number of recommendations leading to the development of those practice alerts. Forgive me if I say standards, because it's just, I'm so often saying the word practice standards. This series of practice alerts are for providers involved in mealtime support. The first ones we're going to go through are, and I'll flag them for you, the mealtime ones, the medication management and assisting with health reviews really do target reducing that risk of avoidable death. And it's really important that we review and share these alerts with staff and even clients to a degree. You know, education is a good thing. We find too that, you know, if you've worked in community services or drug and alcohol or mental health for any length of time, you might be aware that repetition is really necessary, especially for our clients. We can't tell them just once it's a good idea to stop drinking. People need repetition. So we help them to factor their lives around how can they keep getting that repetition, hanging out with people who want to stop drinking, you know, going to the places where they'll hear it. You know, it's the same with mental illness and people who choose not to take their medication on a regular basis. Repetition, it's just that repetition that assists people to learn and to keep on hearing the message. And we need to keep repetition as well. For example, if I'm doing a mental health first aid training, when I'm aware that some of the people in the class or in the room have come without looking at their online material, and they don't know the actual basis of the mental health first aid, which is ALGE, which is an action plan. I will consistently, through that entire training until they're able to recite it to me, continually ask questions and get, you know, structure their learning so that even though they didn't learn it as they were meant to in the online version, by the time we get through half of the training, they know it. So we have to do that too with our staff and with our clients. For example, if I'm working with a provider, I'm going to ask them to tell me what the reportable incidents are. And many of them can, many of them can't. And until they can recite those to me, you know, we need to ensure that the people who should know those things. And that goes for our clients and you guys as owner operators or managers, and helping our clients and our staff to have these front and center. Repetition. So practice alert 1, which is one of the ones of highest risk, the dysphagia, of course. You know, we think, you know, do we really see, you know, what's the problem? Well, you know, I can be sitting opposite a client doing a consultation and they can tell me they have nobody with dysphagia and don't know what all the fuss is about. And then later on in the conversation comes, oh yeah, that person coughs and splutters. And then they start to, you know, well, hello. So people don't know. So we as owner operators and managers need to make sure that we're disseminating that information, and that sometimes repetition, training, documentation, backing all these things up is the way to do that. So people, if they don't recognize the symptoms, can't know what it is. And that is the same logic I apply to if an owner operator can't tell me what the 6 reportable incidents are, why should I have any confidence that they would be reporting them? As an auditor, why would I have any confidence? And I think that's logic. So knowing the signs and symptoms of it, beginning, you know, the coughing, the spluttering, as these 2 lovely providers, these 2 lovely ladies from a provider service did not know. I mean, they've changed their behavior and their entire processes now. If you don't know what you don't know, so it's important that we disseminate the information. The provider obligations in these situations and recommended ways to support participants with dysphagia and what all staff should know. Okay, so that's one of the very serious ones. Imagine what it's like. Do you know what it's like? And I often say to people, when you've swallowed something and it's gone down your windpipe, how horrible is that? That's horrible. It happens a few times in my life and it is absolutely horrible. And I will cough and might wait for my lungs sometimes to have to. I remember a medication went down my, not down my esophagus. It went down my breathing apparatus and I had to wait for my lungs to bring it up. It had dissolved somewhat, but yeah, the coughing and the mucus, which went over a whole day. How horrible would it be to be living like that all the time when somebody's, soft palate is no longer able to close off the airways so that food can go down the right way. Things we take for granted that things work for us. So when you're noticing the coughing and spluttering, that's important. So this is more going to go into some implementation at the end as well. So we're not just going to be talking about the direct symptoms and signs of these things. So the other one that's of great risk is medications associated with that swallowing problem. So certain medications commonly given to people can increase the risk of their choking, which seems a little silly, doesn't it? Considerations including peak risk times and when to get medical reviews for our clients with swallowing difficulties. Medications associated with the drowsiness that impact swallowing. So medications are important from a few points of view. The medications that will help the person to be able to eat in a pleasant way, in a safe way. And then there's the medications we give them for other things which make them drowsy. And, if somebody's on pethidine after they've had a delivery of a baby or, an injury or whatever, you're going to be very careful about what they're going to eat. So we have to be careful about what other medications people are on and the impact that can have on their eating. Medications associated with swallowing problems, which is risperidone, sodium valproate, and olanzapine. So keeping aware of these and having in services, you could have people coming and speaking at your place of business, which is what we certainly did in the days before NDIS. And also, even if you can't do that, at least reading from some really relevant research. The other practice alert, one of my pet hates, if you like, is the polypharmacy. So if you were to go through and do a blitz on looking at everybody's, in a few still homes, see who's got what medications, you'd probably be really shocked to see who's taking what in concurrency with other medications. So I think it's really sensible, and I've developed a register in my compliance system, which records anyone who's taking two or more medications. We need to not let them pile up. The doctors, of course doctors should have a look and see what they're already taking, but do they know? So, if we've got somebody's care 24/7, really the responsibility is on us to help them to get their health managed. Yeah. And it can be as easy as sending their medication chart to the pharmacies who now do medication reviews. And I think they're free. So having them every 6 or 12 months and having that on a register to show that it's been done is a fabulously responsible thing to do. We just want to be really aware of how many medications people are taking, because we need to have somebody look across those to see if they actually interact with each other, or maybe one has become redundant. Short story, when I started at Macquarie Hospital in the mental health national team for benchmarking, one of the stories that they told me in bringing me up to date with what we were doing in that particular project was that about 5 to 10 years previous to my starting that job, there had been such a length of time where everyone in that long-term psychiatric unit had been on so many medications, nobody knew what was given for what and when, and how long they'd been on it. So what they did was, there's a section under the Act, I can't remember the section, I'm sorry, but where you can just stop service, and they send physicians in to walk in, psychiatrists in, specially hired, and they did audits on everybody's files. And the findings from that informed some of the work that we were doing at that job I was taking. So the findings were that there were so many medications taken that nobody even really knew why they were still taking certain things. These were often, of course, mostly psychotropic medications, but also quite a number of Schedule 8s as well, and then other medications. So it was that opportunity for a group of psychiatrists to go in and audit everyone and try to get practices back. Now, obviously the truth was the most common way out of that hospital was was from death. So people were not coming out of that long-term hospital because this was one of those things clouding their progress. So medications are really important to quality of life. Medications are really important to avoidable death. Okay. Epilepsy management also on the high list. Supporting staff to understand epilepsy can reduce the risk for people with a disability to hurt themselves, to not be cared for when they're having that seizure. We need our staff to understand epilepsy plans, and anyone who has clients with epilepsy, their staff who are going to be working with those clients need to be trained. So these practice alerts are useful and they do give good information. The other thing is the transitions of care between disability services and hospitals, not to be confused with the core module transition practice standard, which is just the regular comings and goings from one provider to the next. This one is a practice alert relating to the hospital and the provider. So when someone's coming from hospital to you, really important that you really, look deeply into why they're coming, make sure they don't come without a discharge plan. This is the time where harm happens, being discharged from hospital and going into hospital, things get lost. So if you know all sorts of things about a person, it should go on a transition plan to that hospital if it's a planned admission. Even if it's an emergency admission, there are certain things that you might know about that person if you are 24/7 caring for that person, that should be provided to that person. So if we came out of hospital without a discharge plan, I don't think we'd be happy. So I think that we need to advocate for our clients to not come out of hospital without that discharge plan. And when we're sending people to hospital, we should be sending something with them which outlines what you know and the risks of that person, because it's difficult to collect that information in an emergency situation. Lifestyle risk factors, incredibly prevalent across our sector with our client group. So being aware of the person's alcohol use, overweight, obesity, physical activity, their sleep. Can anyone tell me what the biggest, well, I'm going to say a sleep risk, if you can name a sleep risk for me, and one that if you have, you've got Buckley's chance of getting life insurance. Can you tell me what that is? It makes that big a difference on the risk matrix that most people won't get health insurance, not health insurance, life insurance. You might get a 100,000 one which doesn't ask any questions, but you certainly won't get any higher life insurances. Can't think what that is? Sleep apnea. So the research with sleep apnea is reduces people's life. So when you have sleep apnea with so many of the other things, the risk just becomes exponential. Okay, so sleep apnea is a really big problem. People with sleep apnea also, if you've got clients, and you've probably got a lot of clients who have at different levels of obesity, different levels of drug use, low physical activity, smoking, etc. All of these lifestyle issues, and there might be other issues as well. Not having apnea treated with a CPAP machine or other device, it increases hypertension, it increases cardiac arrest. It really makes that heart work really, really hard. A lot of people with sleep apnea will wake up with nightmares from their body trying to wake them up, but also they'll wake up with their heart pounding. So an enormous killer, that condition. oral health. Who'd have thought? You know, what my experience was that, you know, most people in the aged care, that when I worked 30 years ago, if they could get out of helping people look after their oral health, they certainly would. I mean, I come from an oral health background, and I know it's not everyone's favorite place to be, in somebody else's mouth. Absolutely, you know, I think it's just not one of the nicest places to be. But this is such a contributor to avoidable death, in the form of low nutrition, in the form of the infection that can be present in our mouths. So can we fix it? In and of ourselves? No, but what we can do is we can make sure that people get to the dentist. You know, we can make sure that we do our best to train the staff to at least help them to look after their oral health. Yeah. You can't make someone who's going to fight you. Of course you can't. You can just do the best you can do. Yeah. And there are certain things that you can learn about, such as, you know, some people who hate having their teeth cleaned, some people who don't have the dexterity to do it. Some of them will use a water pick, which is really good at getting the food out of their mouth. There are just things that you can learn, but getting them to the dentist and getting them the oral health care that they need is the least of what we can do. Influenza vaccine. Well, I think that kind of speaks for itself. You know, having a register or a record of who's being who's receiving their vaccines is something that the Commission is suggesting that providers start to do. Take it more seriously, like we have been with our COVID. It's a killer. Influenza can be a killer, especially when people have got all these comorbidities as well, all of these other conditions. All of these conditions, one on top of the other, just increase the risk for people. So there's new resources that have been developed on this topic. All of these practice alerts are on the Commission's website. They have fantastic resources for easy read, in helping families and the participants themselves to understand their condition. They have the practice alert itself, which is lengthy, but good. You know, if you're looking for things to run in your business, you can be running in surfaces, one practice alert every staff meeting. That's a really good way to disseminate information. I have turned all the practice alerts into sort of 10-minute learning modules. So if anyone wants to have a look at those, just try them out for their organisation, please let me know. We try to take the hard work out of the learning so that, you know, instead of, well, what do you think the uptake is of people reading a 5-page document? Probably not much, but they're more likely to do a 10-minute module that has some interactivity. So however we can get the information to people is a good thing. Cardiovascular disease, which kind of ties in with, can have an intersection with your lifestyle diseases, but many other things, also with your sleep apnea as well. You know, there are so many reasons for cardiovascular disease. So anything that's affecting, does anyone know what is the overarching disease name of high blood pressure? Anyone? Oh, there's some comments in there and I haven't even seen them. I'm so sorry. Do we have to have flu or COVID double boost enough? Lou, for what you have to have, you need to, well, they're not asking us for any more at this point. My last intel was that they've stopped at the last booster. But when the next one comes out, that might change. But what we have to have, yes, Jane, that's right, hypertension. Hypertension is cardiovascular disease. Yucky, shocking, isn't it? That's what it is. So if you've got hypertension and you're answering a questionnaire, do I have cardiovascular disease? Sadly, yes. That's what it is. You know, and of course, what else can you think of where someone would have cardiovascular disease? What other clients have you got that might have cardiovascular disease, or what do you think might equate to it? You can have people who have heart valves that are causing problems in their bodies. Obesity certainly can put a lot of strain on the heart, yeah, and it's a lifestyle disease which is most likely going to lead to cardiovascular disease. Some people are very, very lucky, but when we're talking about our clients and our clients that are, you know, complex care and high care, the chances of them reversing that without help, yes, blockages, that's right, all of these things, yep. Even having a little bit of plaque in your vessels now, your cardiovascular disease. So it's really important that we understand what these things can mean and how they can shorten people's lives. And the more developed our staff become, the more intel you're going to get reported back to you, and the higher the care is going to be for our clients. Do I think we can stop all avoidable deaths? No, I don't think it's going to happen, but can we make a difference? Yeah, we can, you know, because if we know nothing and then we increase that by 20%, we've got something, yeah? So there's a lot that can be done. Prevention of respiratory infections. So a lot of people with compromised immune systems or poor health do fare a lot worse than others when they get a respiratory infection. So new resources have been developed. They're available on the NDIS Commission's website. And yes, we have every single one of these practice alerts we have in a short module as well for learning, taken straight from the material that is provided on the NDIS Commission's website. Pain management. Why is that something that's contributing to the shortening of people's lives? Possibly from the misuse of it, I would expect. Oh, something's gone a bit wrong here. Pain management. Just give me a, because I can't see you all, just give me a thumbs up if you're still seeing things, because I just got a weird message from my system. Everything working? Oh, yes, I can hear you. So that's happening. Good. Okay, so pain management. What else do you think is, what else do you think could be, what do you think is a spin-off of pain management? What do you think you might see in a person with complex behavioural problems where their pain's not managed? Yeah, mental health issues. If I were to say to you that my closest colleague and dear friend, who's one of the best behaviour support practitioners that I've ever met, and certainly the auditor that I had sent her to or referred her to said she was the best thing she'd ever seen in a long time, just from some of the successes that she had in her file. First thing she says is there any pain that this person has? What's their physical condition? You know, would you think that a behaviour support practitioner who doesn't have that health background would say that? No, but you know what she finds? She finds that the behaviours she sees in people are often a result of chronic or acute pain that they're feeling right then and there. Interesting, isn't it? Take that one away with you, because that can help you solve problems before they become problems. Reduced mobility, socialization, community access, all of it. You know, you take a person with chronic pain, let's just say chronic pain, and they've had it for a long time, their life has changed. So yeah, the behaviours of concern, Jane, that's exactly right. First question she asks is, it maybe asks herself, but also looks in the file for and then has discussions when she's doing a comprehensive behaviour support plan, is there any pain this person is experiencing? Because she finds it to be such a big trigger for the behaviours that are seen. Yeah. She always has a sort of, you know, the behaviours are going to be for, you know, this reason, this reason, or this reason, and one of them's pain. Okay. So one of the other things we might find that is a problem when people have pain management. what are they going to be taking? Medications. So medications, you know, we've got to be really, really on top of the medications that people are being prescribed, whether they're interacting with each other. And so there's a bunch of new resources for pain management as well, but just knowing when you're in pain, how are you? When I'm in pain, I'm a cranky woman, you know, and sometimes I've had periods in my life of chronic pain over long periods of time. Pain meds can cause such brutal side effects, correct? Pain medication can lower people. Some of it will slow people's breathing, and pain medication can interact with other medications. Pain medication can become addictive if it's a Schedule 8. Pain medication can affect appetite, cardiovascular systems, etc. All of that. So just being aware. I'm not here as a nurse to tell you.
Doing? Huh?
Can you say it again? Can't hear you. No, it's gone. Okay, so yeah, we're not here to talk about medical things, me to just point out to you which are the practice alerts, how you can get good information on them, which has been written by the NDIS Commission. At the end, we'll give some ideas of how we implement these, and what they all could mean for those of you who might not be aware of some of these situations, and how they can contribute to the lives of people with a disability. So medicines that can cause respiratory depression. There's an entire, practice alert on this. Now, this kind of also dovetails into a couple of the others as well, but this is a standalone medications that can cause respiratory depression practice alert. So respiratory depression is characterized by slow and ineffective breathing and can lead to increased carbon dioxide in the body and reduced oxygen availability. Respiratory depression is a serious and sometimes life-threatening condition if it is not monitored and managed effectively. This practice alert provides guidance on supporting participants who are prescribed medicines that can cause respiratory depression. So in having this practice alert, it's going to name for you what those medications are, and you can have some kind of a flag in the way of maybe the register that I have, which asks which are the psychotropic and which are these, you know, which are these type. And then it's in your awareness as a whether you're a business owner, whether you're a manager, service manager, compliance officer, it's in your awareness as to who is a high risk and who you could, you know, manage your support plan and risk strategies around how you would manage them. It will inform that. Comprehensive assessment. So has anyone heard of and I've often talked about it, the CHAP, the Comprehensive Health Assessment Plan? It is something that was done well before the NDIS for people in accommodation services that are 24/7, where they're relying on an organisation to look after them. It is a document which is sent to their GP. Yes. Jane, yeah, that's where I got it from ADIC as well. So I borrowed from there, but it's also had some work done to it by one of the universities, or actually, it's a really good doc anyway.
No? Yeah.
Can someone pop their thing on?
I'll let you through. No,
can somebody put their mute on? There we go. I don't know who it is, but that's okay. So the comprehensive assessment is this assessment. So sometimes it feels like, wow, are we supposed to do all of these things and save all of these people from everything? No, you can't do that. But what you can do is you can send a comprehensive health assessment plan to their GP. I'll just get Shirley to, I think, no, it's not Shirley, it's somebody must have their microphone not muted. But in fact, Louise, it's you, Louise. Could you just mute your, I'll do it. Actually, I'm able to do it, which is good. Sorry, still learning to drive this damn thing. Regular comprehensive health assessments for people with disability improves the detection of these things. So do you need to save everyone? And I'm speaking from a, I'm speaking from a sort of calling a spade a spade. No, you can't do that. But what you can do when they're in your care is you can send them to their GP at least annually to have their regular comprehensive health assessment, which is, a CHAP is one way of doing that. And that way, what your business is doing, what the SILS, Supported Independent Living or Independent Living, whoever, whatever service it's in, it could be personal care that you're giving, which is 7 days a week. That kind of means that there's nobody else out there to do it, doesn't it? So I kind of like to put the 5 to 7 days of personal care in the almost in the 24/7 care, not quite, but I think that's where you have the conversation. If you've got 5 days a week or 7 days a week of somebody's personal care, I would have a conversation with the family, the carers or the guardian, if they're the people running the show, about whether there is anyone that is able to manage, is there someone looking after this person's oral health? Is there someone taking care of these, getting them to the doctor? If not, we'll be happy to do this chat and send it to the GP with the client. And then we are simply responsible for facilitating all that the chap says needs to occur. Okay, so that takes away any idea that you are responsible for everything that happens and doesn't happen to that person, and that you can fix them. You can't, but you can help them to care for their health by following a few simple strategies. So that's good. So we've rehashed that CHAP and it's been up and running for at least a year and a half or something. So, and I've been getting feedback. Doctors were a bit surprised, but they weren't unhappy about it. So they're a bit surprised, but not unhappy to see it, which is good feedback. Because I think sometimes if people with really complex care present, I don't know, probably not sure what to do. When you've got something that's a bit of a direction for you to follow, I think as a practitioner, you think, yeah, you know what, I can do this. And this way, after the first one, it gets easier. You can start to really see what's being managed in that person's life. Now, implementing it. Now that we've gone through what those practice alerts are as they stand now on the Commission's website, you have to ask questions to know. It probably came to your mind, how would I know that? How would I know any of this? We have to ask questions. And when I was doing an audit yesterday and someone was still running off, they were using my policies and procedures. This was an internal audit, but they were using an old set from 2 years ago. And I said, well, I know you've got the new ones. And they said, yes. And I said, but you're using the old one. And so what I can say straight away is that I know it doesn't include anything from the practice alerts, my older comprehensive assessment. So I know that you haven't been collecting the information that's required, because that was before the practice alerts. So in saying that, you have to ask questions. If you're not asking them, you can't be implementing all of these strategies for practice alerts. So you're somewhere along the line, your assessment form needs to ask these questions. So what I've done is put all of those new practice alert conditions into my assessment form, so that it's unavoidable to come out of an assessment without asking those of the client's, carers, family. So you can find out without knowing, there's nothing you can do. You got to record those answers. So if they're not recorded, you can't refer back to them. Ideally, they need to be a part of the support plan or the care plan, if you're doing nursing, that you're going to be creating for that person. So you've got to ask, you've got to record, and the information must be used. Now, I know that sounds really strange, but it does. You've got to record, you've got to then use that information. If you ask it and record it and then don't do anything with it, it's of no use to you. So ask the information, record the information in a place that is going to be seen, and that's something, that is functional, and then you use it to build either the care plan or the support plan for that person. And one of those examples is by using the comprehensive health assessment plan, which goes to the GP. So how do we make sure that this all happens? We have to have policies and procedures that talk about the process that we've just outlined. And I have that in my assessment policy. We have to have job descriptions that say this is something we expect from you. We have to have training and onboarding and training and encouragement after that to keep up the momentum. A person can't do something if it's not in their job description or you didn't tell them about it. They have to know about it. We have to have these scheduled risk assessments. As you know, it's minimum of one year. A risk assessment has to be completed and or renewed. We have to be reviewing them. We have to be reviewing and observing our case notes, or we have to have processes in place to do so. We have to have supervision of staff, whether that is that you're doing that 5 minutes a week, or whether you're doing it for half an hour a fortnight, or you have 1 monthly meetings, or you do it in some really incredibly innovative way. It still has to happen. Without it, number one, you're failing you're going to get a non-conformity on the supervision standard, but also you're missing out on that opportunity. You can't reinforce things and help people where they have problems in terms of your staff if you're not meeting with them and speaking with them and finding out how they're going. And we have to have continuous quality improvement, which is active and proactive. So if you're getting lots of incidents and you're making changes and improvements because of those incidents, that's reactive. If the majority of your quality improvements are based on things that go wrong often. So what you want to try to move from is you want to start going into a proactive quality improvement. So you see things that could be improved, but they haven't become a dangerous incident or complaint at this point. So taking proactive steps to improve things before they become an incident or a complaint. So we want to try and move our maturity in quality improvement from bad things happening a lot and then fixing them, from I see something that could go wrong and I can put steps in place now to put a new process in place, and therefore that becomes proactive. I'll just go to the chat for a sec. Why does it keep showing it to me like that? So I wanted to do that in a chart for you, just lastly. So if we've got implementation, which is what we're going for, you can use this for practice alerts, or you can use it across anything. You need to reinforce. We talked about the reinforcement and how much value it adds. In fact, it is what would you call it? A game changer if you have reinforcement. The continuous quality improvement, we want to learn from what we do and where we can see we can do things better. We need to risk manage, of course, and definitely in this situation, it requires risk management. We need to manage the knowledge. We need to make sure that the staff that we deploy, they know about this. Because if they don't know about this, it's like when I say to a provider, owner operator, tell me what the 6 reportable incidents are, and they can't tell me. How can I have any confidence if they don't know that they could report them? Because they don't know what they are. So they're not going to go, well, I guess that's ridiculous. So knowledge management, we need to make sure the knowledge is embedded there, whether it's through the module training or whether you do it through your own in-services you do, or however you want to do it innovatively. We need to manage the knowledge. We need things documented. So this is our framework. Can anyone, and I'd love to hear, tell me what of this list here on the right, when we've got to have something documented, which of these strategies will help you meet that? can you tell me which of those categories you might deploy for meeting your documentation need? Thank you. All of them, yes, but is there one in particular? I mean, we're just talking about our documentation need. I would accept all of them, yes, but are there some very specific ones? Reviews, yeah. I would have gone for, if I need it documented in the first instance, there's a few layers. I would say, oh, hang on. Yep, all of that. So there's something in all of them, isn't there? In the initial stage, you would want to have it in a policy and procedure. If it's not there, nobody knows it's supposed to be done. You'd want to have it in the job description of the person. You would want the code of conduct to back it up for you. Your reviews documented, risk assessments documented, initial assessment documented, supervision assessment documented, performance appraisals documented. So yes, all of them in a phased approach. You initially need that policy and procedure and that job description, yeah? So this is for a seamless implementation. Reinforcement, we talked about the capacity and how people's knowledge and practice grows when we reinforce things. Which of these will assist you to reinforce? Please feel free to put your mute off. Don't mind if there's a little bit of noise, that's fine. The question, sorry, Jane, the question was, for reinforcement, which of these on the right-hand side would you employ to reinforce knowledge?
Reviews.
Clinical supervision, your performance appraisal.
Yeah.
Code of conduct. Oh, I don't know if code of conduct.
But you got that. I think I was on the same page when I wrote it. So supervision, performance appraisal, onboarding is the initial giving of the knowledge. So that I would have said for knowledge management, you're down here in onboarding, in your policy and procedure, it's got to be there, or people can't see it. In the job description, it's got to be there. Your code of conduct is there, not so that, from my thinking, the code of conduct says you will follow your job description, you will follow the policies and procedures, you will attend staff meetings and things like that. So that's to hold your staff and help, to know this is our framework of ethics and legalities that we want you to follow. It doesn't have to outline every single thing you expect from them, because this will and this will, yeah? But it's the one that ties them. Here's your code of conduct, and when someone breaches the code of conduct, there are certain things that we can do, and that will be whatever you've outlined in your employment contract that you want to do in those situations. There are some breaches of a code of conduct where you are able to dismiss someone. As you would know, there are serious things, but this is how we tie these things so that they're implemented and they're tightened up so that people can't poke holes in them. So we want to be sure that, our code of conduct always points towards following policies, procedures, following job descriptions at the minimum, because they're the things that are going to be housing what we actually want from our staff. But also from a staff's point of view, they can't do something for you if you didn't tell them what to do. So we must be able to put in their job description what we expect from them. It should be an almost fluid document that is updated as need be. Then our risk management. Which of these on our right-hand side we're going to employ to make sure risk management occurs?
Risk assessments, policy and procedure.
and the reviews. I think the risk assessment and the review of the risk assessment is really important. So here we are, we have a few tools here that we use to make sure that occurs. And your CQI, so we've done documents, we've done reinforcement, we've done the knowledge management, we've done risk management. CQI, if we're going to continually improve our processes, what would we need to make sure is occurring so that we are figuring out which things need improving?
Reviews and performance appraisal would come into it as well.
Definitely, it can help with all of that. That's exactly right. So just from, so that's your framework. You know, if you want to implement something, it has to have a number of components, and you need to bed it down so that there's not much wriggle room and you can't miss things. So it really comes down to, because I know I've had people sit back and say, oh, it's so hard. How do we, you know, I've got 300 staff, we've got, you know, 500 clients, or that was just figures I pulled out of my head, but we can't do it unless we have a system, you know, and that system is, you know, in place and implemented and constantly, you know, reviewed. So we need systems, and then it's all doable. And remember, we're not expected to save everyone. There's an expectation on us that we will help them to manage their health with all of the, with anything that is at our disposal to do so. Make sense? Any questions? Contributions? Experiences? The safeguard word says it all. Yeah, I think so. Is that, I missed the question? Something?
Hi, it's Jane. I think the word like safeguards is, and I come from a clinical background, is the premise you come from in the work that you do, is that through bits and pieces of the work you do from when you start working with someone, you're looking through that safeguarding lens.
Yeah, I think that's a really good way to put it. I like that. I think, you know, the safeguarding could even go around the circle here, couldn't it? You know, I think a bigger circle around here could be safeguarding. We are safeguarding. We can't fix, we can't magically wave a wand, but if we follow some proven systems and look at it as though we're trying to safeguard this person's health and life, then I think we can do well in all of the areas. Anyways, if there's no other questions, you've been very quiet this time, Amy. If you're there, she's probably not there. Anyway, this will go out as a recording to everyone who enrolled. And if you have any questions, you know where to find me.
Thank you so much.
Yeah, pleasure. And remember, if you wanted to put yourself through those 10-minute modules, please let us know, and we can let you know how much that is. We don't charge very much for our modules. Thanks for coming along, everyone.
Thank you.
Okay.
Thank you.
Thank you.